Well, thank you, Anita, so much for the kind introduction. And I was worried whether I should stop training people on functional echo and ventilation after listening to the previous speakers, that we should be focusing on other things as well. So I'm trying to use technology, functional echo and ventilation, but yes, nutrition should never be ignored. And we are trying to abide by the principle of Hippocrates that let food be thy medicine and medicine be thy food. So nutrition is equally important, and we should not get overboard with anything. We have to be moderate, like Dr. Ashok was telling us. We should have the good points and bad points of everything. Well, in this presentation, what I'm trying to cover is human fortification. So basically, I'm going to take you through a small journey, the story of premature babies. What are their concerns? Do we really need to fortify human milk? Who are the candidates for fortification? When should we start fortification? When should we end it? What are the methods available? What are the various types of fortifiers available? Few things I have left for the workshop, like the fortifiers and recommended intake and all those calculations that we can help in the workstations. Supplements, I'm going to talk and DHA. Vitamin D and calcium, phosphorus I have intentionally avoided because you have a session on osteopenia of prematurity and I should not impinge on the other speaker's field. Now, okay, so some of the slides are not being displayed. So I wanted to show you basically the story of an extremely low birthday baby. I'll tell it impromptu. So we have a chart called Ehrenplan chart, and we all have gone through that chart, right? If you look at that chart, you will see that babies who are extremely low birth weight, they start to lose weight and they continue to follow a centile which is lower. So 95% of extremely low birth babies are going to have growth failure. And when we did a study in 2010, we looked at the growth outcomes of our babies in the NICU. We found that they were not even following those charts. They were even faltering lower than those centiles which were plotted by Ehrenplan. To give you an overview, if you look at this data, this is the centiles of the baby, the Z-scores of the babies born in our NICU. And what happened at discharge, they had altered in all the anthropometric parameters. So there were 1 Z-scores lower in weight, head circumference, and length, all of them. And when we talk about the long-term outcomes, what happened if we compared with normal weight babies, they have lower developmental quotient, motor index, and mental index. So the story which I am trying to build is that premature babies are at risk of growth faltering, and they're also at risk of having some developmental issues later on in life. Now, this is a study which was published by Ehrenplan. It's beautiful data which shows that babies who gain lesser weight are at higher risk of having cerebral palsy. So what it did, he analyzed the various risk factors, and then by adjusting for these risk factors, he found that babies who gain weight of say around 10 to 12 grams per kg per day had a risk of cerebral palsy around 20%. While babies who gained more weight, more than 20 grams per kg per day, the risk was just 5%. So that again emphasizes the importance of growth and developmental outcomes. So they are linked together. You cannot look at them separately. Again, the table has disappeared. I think there is some problem. So there was one more data I wanted to share with you, which was a study by Stevens, and what Dr. Girish had showed in the morning, the importance of nutrient intake. So if you give additional just 1 gram per kg of amino acid in the first week of life, the developmental quotients, they improve by 8 points. And if you give just 10 kilocalorie per in the first week of life extra, the mental index, they improve by 4 points. So the basic message which I'm trying to give you is that growth failure is very common in extremely low birth weight and very low birth babies. They're at risk of having a poor neurodevelopmental outcome. These are closely linked. And if we optimize the nutrition, then it can improve the growth and probably the long-term outcomes of these babies. Now, coming to human milk. Now, a lot has been said about human milk already, and we understand that human milk is an elixir for the very low birth weight babies. That's absolutely a beautiful component which God has created. And there are several systematic reviews which have shown that there's reduced risk of infection, necrotizing enterocolitis, chronic lung disease, ROP. There's dose-related decreased risk of mortality, NEC. It also improves the cognitive developmental scores. The short-term growths are slower, but in the long term, there's no difference. So definitely human milk is the best choice when we want to start enteral nutrition. In the absence of mother's own milk, we have to go towards donor human milk if you're not able to get mother's own milk because of any other cause. Donor human milk is advantageous, and in systematic reviews, it has been shown that it decreases the risk of NEC if you compare it with formula. The growth might be slower initially, but in the long term, there's no difference in growth with either of the interventions. So what we want to do is that we want to optimize the use of human milk. We want to get all the benefits of mother's own milk if possible. But there is a problem. We can't just close our eyes like an ostrich. There is a problem. The problem is that if you look at the components of mother milk, this is a study which we published recently. And if you look at the protein intake gradually, what happens? The protein intake comes down. It comes to close to 1 gram at the end of 1 month. And even when we analyze the calories, what we traditionally read in books, close to 67 kilocal, we were not able to get that kind of calories in the mother's milk, which we analyzed. Other authors have also found similar findings that the protein content, the sodium content, the zinc content, all these usually diminishes as time progresses with lactation. But at the same time, my previous speakers has emphasized the point that we need to give higher protein. We need to give a protein of close to 3.5 to 4 gram per kg per day. The calorie intake is around 1.5 to 140 kilocal per kg per day. With this composition of human milk, we are unlikely to reach these recommendations, especially for protein. We might reach the calories only at the lower end. The proteins and other ingredients like sodium, like zinc, like vitamin D, we might not be able to completely fulfill the nutritional requirement of premature babies by human milk alone. So what is the way out? The way out is that we have to understand there are limitations of unfortified human milk, which can lead to slower growth. The BUN, serum albumin, pre-albumin, the markers of nutrition might decrease with time, and we might be putting the premature baby at risk of certain disorders like osteopenia, zinc deficiency, iron deficiency, late hyponatremia, vitamin A and vitamin D deficiency. Now, this is the composition of human milk. If we give an infant 180 ml per kg per day of human milk, we might reach a calorie intake of 120 kilocal, protein intake of 1.8 gram per kg, calcium of 60 and 28. Now, these are far below the recommendations, what has been given by Aspirin in 2022. If we can fortify this with either of the fortifiers available in India, I'm not going to name them, just I've just put it A and B, we will be able to reach the requirement G, protein, calcium, phosphate, and iron at least. We may still have to supplement some of them. So the point I'm trying to make is that human milk is the best, but there are risks of nutrient deficiency, risk of extrauterine growth restriction if we just give the infant only human milk. So are there benefits of fortification? Do fortification of human milk really help? Is it beneficial? Now, if you look at the Cochrane review published in 2020, there are short-term benefits. There is improvement in the weight gain, improvement in length, and improvement in head size. Although these are very marginal, but there are benefits in the short-term anthropometric parameters. There's no difference in necrotizing enterocolitis because there's a lot of concern that human fortifiers could lead to NEC. If you look at the neurodevelopmental outcomes, they are not statistically significant, but infants who receive fortified human milk had higher Bailey's mental developmental index and psychomotor, motor and psychomotor development index by 2.4 points. These results were also analyzed for infants who are born in lower middle income countries like ours, and for infants who are very low birth weight, and the results were similar. They had gains in the anthropometric parameters and not much difference in the long-term outcomes. Now, there are various kinds of fortifiers which are available. You can have monocomponent fortifier, which have protein only, or which can have carbohydrate like glucose polymers, which can have fat only, which could be fat emulsions, or a mixture of carbohydrate and fat. Or it could be multi-nutrient fortifiers, which we have in our country, which could be of bovine origin, that is from cow milk, or could be human origin derived from human milk. And it could be traditional fortifiers. The new generation fortifiers compared to traditional have a higher amount of fat, so they have low osmolality. People are also trying to get fortifiers from bovine colostrum and donkey milk. That is what is like coming up in research now. Human origin fortifiers could be both. We have liquid usually, and they are acidified to decrease the risk of infection. They have their own issues. So the second message which I'm trying to give you is that human milk has myriads of benefits. We're absolutely 100% sure about it, but alone it might be insufficient to meet all the nutritional requirement of a premature, very low birth weight or an extremely low birth weight infants. Fortification could be a way to meet this limitation, and there is evidence of at least marginal growth benefits if you fortify human milk. That is the current evidence which we have. So in whom do we really use fortification? Who are these candidates? And there was a lot of hue and cry about doing routine fortification 10 years back. And even our national guidelines were not very supportive of doing routine fortification in babies. Only babies who failed to gain weight, it was recommended that they should be receiving fortified human milk. Now the scenario has changed a little bit. Most of the international bodies, including our national guidelines, the Anup, Anup, European Milk Bank Association, all of them recommend to routinely use fortified human milk in infants who are less than 1,800 grams birth weight. A WHO recommendation, the last we had in 2011, still recommends that it should be used for very low birth weight infants who fail to gain adequate weight despite full volume human milk. And Anup guidelines leaves a caveat that if it's a resource limited setting, then you can use fortifiers in certain candidates who are not gaining adequate. By and large, most of the international bodies have moved towards routine fortification of human milk in infants who are less than 1,800 grams birth. Now, when should we fortify? Traditionally, fortification is started when the infant reaches around 100 ml per kg of enteral feeds. That has been what we have been practicing for many years now. So people have looked into the feasibility and safety of starting early fortification. The hypothesis that when you stop parenteral nutrition and you're building up the enteral nutrition, there's a phase when there is a phase of nutritional deficit. So we are trying to start human milk fortification right at that phase. Now, in two systematic reviews that I have presented here, there was no benefit of starting early fortification that was in less than 100 ml per kg per day. In the first study, they looked at the time to regain birth weight. There was no difference. In the second study, they looked at the various anthropometric parameters. There was no difference in those parameters. Rather, the duration of hospital stay was higher in the early fortification group. So that is the evidence which we have. If you look at the randomized controlled trials which have been published in the last decade, these are the various volumes in which fortification has been started, varying from 40 to 100 ml per kg per day. That is the reason you will find that the recommendations have come up from the European Milk Bank Association in 2019, our national guidelines, NNF 2020 and ASPEGAN 2022, all of them have given a wide range where you can start fortification from 40 to 100 ml per kg per day. So the expert opinion is to start early fortification, although if you look at the systematic review and meta-analysis, right now there is not enough robust evidence which is favoring early fortification. When should you stop fortification? So there is a lot of disparity in the Indian institutes where they stop early, someone around 2 kilos, someone around 3 kilos. Now, if you look at the evidence which we have, there are some studies which have continued fortification beyond discharge or beyond 40 weeks. So in this randomized controlled trial, which had 320 infants, there was no difference in the long-term outcomes if fortification was continued beyond 4 months. But when they followed up these infants at 6 years of age, they found the infants had improved lung function, decreased risk of allergy, and low. Another RCT which was done by Connor et al., it found that fortification till 12 weeks helped the infants to get dietary intakes closer to RDA and improve short-term growth. And when they followed up these infants, they found better bone mineral content, better growth, and even visual acuity. In the last study, which was done by Jikuna et al. In 2016, they found that if you fortify for 4 to 6 months of corrected age, there were higher motor language cognition score by 3 to 5 points, but it was not statistically significant. So if you look at the evidence of fortification beyond discharge, again, the evidence is not very robust. There are some marginal benefits in some of the evidence. There's still lack of evidence. And the last guideline which we have from any international body is as per in 2004, which says that you can fortify beyond 40 weeks till 52 weeks, but you should be following the growth charts. If your infant is already catching up in the normal centiles, you should stop fortification. So the evidence is weak regarding the candidates of fortification, regarding when you should start fortification, till when you should continue. But what we have now currently is that candidates who are birth weight of less than 1800 grams, in those infants, you can start fortification routinely. You can start early as 40 to 50 ml per kg per day, and you can continue longer in view of marginal benefits, and there's no harm. It does not interfere with routine direct breastfeeding. Now, what are the various fortification regimen which people use throughout the world? So one is standardized. So standardized means it is more like a blind kind of fortification, which we all are doing perhaps in our NIC. So what we do, we have a multi-component fortifier, and whatever is based on the manufacturer's recommendation, we add in the particular amount of human milk. So 25 ml, you mix one sachet or whatever. It's very practical. It is easy to practice. And it is based on assumption of human milk composition that, okay, this will contain this much of protein, so this will fortify by this much levels and probably meet the recommended outcome. Now, targeted fortification is something which was brought into light by Paul Berger in 1999. And what the concept is here to analyze the human milk, the mother's own milk, look at the specific content of the macronutrient, the protein, the calories, the fat, and then looking at what is the deficit based on the recommended RDA, you fortify individually. So if the protein is less, you fortify the protein. If fat is less, you fortify the fat. The problem, it is extremely labor intensive to pool the human milk, collect it, then analyze it. So you need a good team for analysis, for doing lactational counseling as well, to make sure that everything is done in the proper way. Now, the third concept is of adjustable fortification, which is propagated from Europe by Aslang Nogu. It's very difficult to speak his name also. So, the concept is of adjustable fortification, where you're trying to monitor the blood levels of blood urea nitrogen twice weekly, and you are taking it as a surrogate marker of protein adequacy or protein accretion. So if your blood urea level is between 10 to 16 milligram per deciliter, you're okay with that particular level. If it is less than 10, you will need to fortify proteins further, whatever you're doing. If it is more than 16, then you come one level down in the fortification. It is not intensive, of course, but you need to do the samplings. That is the issue. And you can actually monitor the protein intake. Now, which one to do? Standardized, targeted, adjustable. So that's the confusion, right? Now, problem with standardized fortification is that you presume that human milk has this much amount of milk. And when people analyze, they found that the presumption was wrong. And in fact, human milk had less protein by almost 0.5 gram per deciliter at all these weeks. So your presumption is not right. What you are thinking in blind fortification is not actually happening. We followed a regime of standardized fortification, and we were little aggressive, as Dr. Ashok told you, in 2015-13. And at that time, we didn't have good fortifiers in India, which contained 1 gram of protein per 100 ml of milk. So we had the old fortifiers, which contain about only 0.4 gram of additional protein. So this is the one where we continued the aggressive regime. And despite the aggressive regime, which we continued targeting at 3.5 to 4 gram per kg per day of protein, we could not reach the recommended levels of anthropometric growth. So the growth velocity was only 13.6 gram per kg per day. OFC was by 0.72. Length was okay, 0.94. And we followed this infants at 12 to 18 months as well. There was not much difference with higher protein, maybe by 2-3 points in the motor and mental developmental quotient at 18 months. So with standardized fortification, we were not able to achieve the optimum growth. This is what we found. So how do we do adjustable fortification? Now, this is a regime of adjustable fortification. You start off with standardized fortification, that is called level 0, when the volume of feed is around 50 to 80 ml per kg per day. Now, you do the B1 levels twice weekly, and if the B1 level is less than 10 milligram per deciliter, you increase the fortification to next level. So next levels means you add additional of 0.4 gram of protein supplement. If it is in 10 to 16, there's no change. If it is more than 16, you come down by 1 level. So this is the adjustable fortification regime, which has been given by the European Milk Bank Association. And this is practicable, yes. But what is the evidence which we have in comparing these three regimens, standard versus targeted and adjustable? So this is the last Cochrane review, 2020 published. And if we compare individualized versus standard, individualized is better in terms of anthropometric parameters. There is improvement in the growth. If we compare targeted versus standard, again, targeted is better in terms of weight and length improvement. If we compare adjustable versus standardized, adjustable is better in terms of all the three parameters, weight, length, and OFC. If we compare targeted versus adjustable, targeted fare better in the weight. There was no significant difference in the length and OFC. So overall, it seems that targeted or adjustable scores better than standard fortification in terms of short-term anthropometric parameters. Studies for long-term growth and nutritional outcomes have not shown benefit. So the next message is that yes, better protein content improves growth. There are three fortification regimes. First is standardized, which is very easy and practical. Next is individualized, which could be targeted, where you target the recommended intake, or it could be adjustable, where you adjust the protein based on B1 level, presuming it is a marker of metabolic response. And overall, the evidence currently which we have is individualized is better than standard, although we're not able to practice it currently because of lack. Now, another controversy, human milk-based fortifier. Human milk is the best, so why not get the fortifier from human milk? Why do we get the fortifier from cow milk and donkey milk and all this kind of stuff, right? So hypothesis is that it will decrease the risk of necrotizing enterocolitis. And the first study came in 2010 by Sullivan et al. It was a 3-limb RCT, and where in one limb they gave human milk fortification was done at 40 ml, other one 100 ml, and other group they gave the bovine fortifier. The sample size was calculated for reduction in PN days, not for NEC, because you will need much larger sample size if you want to see the difference in NEC. And they found that the NEC or death was only 6% in human milk fortifier, base fortifier, whereas fortification was done at 100 ml. And in human milk fortifier used at 40 ml, it was 8.5%, and in bovine fortifier, the risk was 20%. So it showed that the odds of NEC or death was much higher when bovine milk fortifiers were used compared to human milk-based fortifiers. But we have to understand this was a sponsored trial by Prolecta. So there was definitely certain degree of bias, and we should take it with a pinch of salt. Now, Lucas et al., they went one step further. They analyzed this data, they merged it, and they analyzed groups, completely 100% human milk with human milk derived fortifier and cow milk derived fortifier. And they found that with cow milk derived fortifier, the risk of NEC was 4.2 times, and the risk of NEC requiring surgery or death was 5.1 times. So it is again a kind of extraction of result from the same study. They found that human milk-based fortifier is beneficial. So what did we do now? We have to look for more robust evidence, and evidence keeps on changing. So you should be aware, keep your eyes open. So another trial was published, Optimum trial. Now this was a more robust design. It was triple blinded. It had 127 infants, and here also the sample size was based on the outcome of feed interruption and reduction of feed volume. So what they found, whether you used human milk-based fortifiers or cow milk-based fortifier, there was no difference in heat intolerance. There was no difference in necrotizing enterocolitis. They followed this infants during follow-up till 2019, 18 months. There was no difference in long-term growth, no difference in long-term. So human milk-based fortifier did not help to improve growth, did not decrease the risk of NEC, mortality, or did not improve long-term. The Cochrane review included only this study, which is the optimum study. It excluded the study by Sullivan because it appeared that the previous study was biased and it was sponsored by the company. Now, there are already two systematic reviews which have been published on this. The first one, Ananta et al., published in 2020, it did show that there is low risk of NEC and lower weight gain, a low risk of NEC in the group where human milk fortifier was used. But when they did a sensitivity analysis, that means they excluded trial which had degree of bias, then there was no difference in necrotizing enterocolitis or death. Other meta-analysis was published where they took both the studies. And if you look at this meta-analysis, the entire result is biased by the study of Sullivan et al., which is the first study. Look at the weight of this study, which showed benefits in favor of human milk-based fortifiers. So you have to keep your eyes open. You cannot just go by your practice or what you hear. You have to look at the evidence critically. There is some degree of bias as far as human milk-based fortifiers are concerned. A lot of the study was industrial funded. There's no difference in robust trial. NEC was not the primary outcome in any of their trials. There are issues how you're going to organize the donor pool of human milk at the level of society. There are institutes where doing marketing and finances are involved, and there are ethical issues where you are using money to purchase human milk and building up fortifiers. And the evidence is also not very supportive. The next ongoing trial, which is going to be published, is Swedish imported trial. Now, even here the subjects are only 222, and it is also not going to give you enough evidence in the future. So if you summarize all the evidence which we have on human milk fortification, if you do multi-nutrient fortification, you have some marginal gains in short-term anthropometric parameters, and there's no difference in long-term outcomes. Individualized fortification, you have some benefits in short-term anthropometric parameters like weight, length, and head circumference. No difference in long-term outcomes. With respect to timing of fortification, early versus late, currently there is no evidence to support any of them. With respect to discharge, post-discharge fortification, there are some studies which have shown beneficial effect on visual acuity growth. And human milk-based versus bovine milk-based fortification, currently the evidence is not robust enough to support human milk-based fortification. Okay, I'll finish in 5 minutes. So we discussed about iron in the morning. Dr. Ashok already showed you about the recommendations of iron. I'm just going to show you the science behind it. Early versus late iron, there are around 18 RCTs which have been published. And early iron therapy, that is when you start iron at 2 to 3 weeks of age, it leads to better hemoglobin, better iron stores, and decrease the need for transfusion. Long-term outcomes, we have the largest RCT was by Franz et al., and it did show some minor benefits in terms of abnormal neurological examination, which was more in late iron compared to early iron. Now, the issue is that with iron, we still have lack of RCTs in preterm infants where it has shown to improve the long-term cognitive benefits, although there are studies of latent iron deficiency in late preterm and term infants where iron supplementation has improved the cognition. These are the standard recommendations that you start 2 to 3 milligram per kg per day of iron at 2 weeks, you monitor the serum ferritin, and you should supplement in 6 to 12 months of corrected age. Now, one important micronutrient which is ignored is zinc. There's a lot of evidence which have come up in favor of zinc. Zinc has been shown to improve anthropometric parameters, motor developmental scores, and decrease all-cause mortality. The recommended intake is 2 to 3 milligram per kg per day. And it is a nutrient which you should look for in the fortifier, whether it contains zinc or not. And if not, then you should supplement this. Again, DHA has been talked about a lot. And the evidence which we have in favor of DHA is from the DINO trial, which was published in 2009 in JAMA. where it improved the mental developmental score, especially in girls. And at 18 months, their severe delay was lower in supplemental group. But if you look at the primary outcome, there was no difference. And there's another trial of DHA called N3RO trial, where DHA was used to thinking that it would decrease the risk of chronic lung disease, but it happened that the CLD or death was increased in the DHA group, and it was not beneficial. Now, when you followed up this infants 1 to 7-3, recently published in NEGM, they found that in the supplemented group, they have better full-scale IQ scores. So maybe if this trial comes in the meta-analysis, you might found that there is improvement in the long-term outcomes with DHA supplementation. So currently the guidelines are that you ensure a DHA intake of 30 to 65 milligram per kg per day, and ARA of 30 to 100 milligram per kg per day. So the key messages which I'm trying to emphasize here is, yes, fortification of human milk is beneficial. The benefits are marginal in terms of short-term improvement in growth. Long-term benefits are not yet seen. About the fortification regime, individualized is better compared to the standard fortification. If you can do it, if it is feasible in your NICU. Compared to early versus late, the recommendations are to do early fortification at 40 to 50 ml per kg per day. Evidence is not very robust. This is based on expert opinion. Regarding when to stop fortification, you can continue it longer, to 44 to 52 weeks also. There are some studies which have shown marginal benefits of growth and some long-term outcomes. With regards to human milk-based versus cow milk-based fortifiers, there is lack of unbiased evidence currently. The evidence is not very robust. And about the nutrition supplement of zinc, iron, calcium, phosphate, although you have to look at what you're giving to the baby, whether it is a fortified human milk or human milk alone, look at the guidelines. And if you're not able to meet the RD, you have to supplement additionally. And thank you so much for having time. This is Ziegler. I mean, he was one of the person who was very passionate about nutrition in premature babies. And in fact, a lot of studies which we have in the past has come from Ziegler's group. Thank you so much.